Hi, this is Brian Kim. I'm going to share with you episode number 6 in the From Good to Great series. And this is a patient with extreme head jerking, not only extreme head jerking, but also restless leg. In my experience, patients with restless leg syndrome don't have just restless leg, but they have restless everything, a restless body. And this can also manifest as a head jerking phenomenon. And so you're going to see why this is a From Good to Great number 6 case tip, because I'm going to show you how to control the eye under suboptimal conditions. And so this is really the crux of it all. Do not have your instruments free floating on the patient. So when you have your instruments in the eye, you should not be having your hands floating above the patient. You should always, always, always have your hands resting on the patient's face. And why is that? Well, obviously the patient may not like that because they feel your hands on their face, but from a security standpoint, it gives you a steadying surface to steady your hands as you're doing the surgery. But more importantly, in this particular case, if your hands are resting on the patient, if they suddenly move, your hands will move with the patient's movement. If your hands are floating over the patient's face, then if they suddenly move, you could actually rupture the posterior capsule or do something really awful. But while your hands are on the patient's face, if they suddenly move, your hands will also suddenly move with the patient. And this is a much more safe situation. So you can see here, I use a corneal marker to mark the central cornea. And then I make my paracentesis incisions first on the right side and then the left side, making sure I'm parallel to iris plane to create a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine. Look at the movements. The patient's moving so much that the cannula comes out. But remember, I have my hand on the patient's face as I do all of these maneuvers. And this is intracameral epinephrine. And then some dispersive viscoelastic to fill the anterior chamber. You can see this patient has a Bell's reflex. This is the left eye. I'm using the cannula to control the eye. And then I'm going to try to quickly perform my triplanar corneal incision. I make a vertical groove. You can see the patient was moving. I wait for the patient to settle down. I made the groove, wait. I place the blade into the deep part of the groove tunnel, and then I enter very quickly. You see the patient suddenly moved out of nowhere while I was withdrawing the blade. I don't think I widened the incision too much, but I think that went rather well. I go ahead and use my sharp tip Haldi Percar as I puncture the center, pull towards me, grabbing the right side of the tear. And you want to do this fairly quickly because this patient is not trustworthy. And I'm trying to be rather expeditious. Doing my orexis, I'm going rather fast here. Centration and size, of course, is very important, but you just need to have a complete orexis. You can see I was about to finish and the patient suddenly moved once again. I let go when the patient moved of the flap, and then I finished the orexis. This is the capsular fornix hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave, decompress. You see the patient's moving. I'm just kind of riding the wave as the patient's moving. I sweep on the left side and then the right side. Again, the patient moves again. And then I'm just trying to carefully sweep. This is a rather soft lens. It's kind of falling apart. I did not do the lens lift technique. Again, this is an older case. I would have otherwise lifted and tilted the lens to decompress the bag. But nonetheless, I go ahead and lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. Now that I have two instruments, I feel more confident. I have control of the eye, placing the chopper around the lens. So this is why I take the chopper out. And why is that? Because I'm so far away from the center because of the patient's extreme head movements. I had to recenter myself, and then I go back in with the chopper. So again, I had to recenter, place the chopper around the lens, hooking the peripheral lens, placing the chopper subincisionally, tilting it vertically. That's the double chop, placing the chopper on the right heminucleus, pulling it essentially toward the phaco tip. That is a cross chop. You can see I'm going to move rather quickly with this case because this patient is not really predictable. And really, can I block this patient? I'm not sure if blocking would really help. Maybe, maybe not. But you can see the extreme head movements. This patient is, again, doing the best he can, but it's just really, really difficult. So I just come out, just gather my bearings one more time, and I go back in. I got the first quadrant out. I'm going to turn that second quadrant a little bit towards me. It's not really moving, so I get underneath the lens, and then I'm going to just pull it up out of the bag. And that's the beauty of this technique. I'm always placing the chopper around the lens, so I have no trouble hooking the peripheral lens and popping it out. You saw that lens piece is essentially sub-incisional. There's no way the phaco tip can directly go for that piece, so you really need that chopper. I was able to hook the lens from the periphery and pop it up out of the bag. So then I place the chopper around that second heminucleus, pulling it essentially toward the phaco tip, fracturing the lens completely in half, using some vacuum to lift that quadrant up, hugging the lens from the other side with the chopper, crushing the lens between the instruments, and then emulsifying the lens piece. Thankfully, this is not an extremely dense lens. I'm able to still fracture the lens fairly easily using fairly low amounts of ultrasonic energy and vacuum. Really, the main issue here is making sure I don't cause a problem because of the patient's severe eye movements. In this case, I decide, okay, I'm done. I'm going to leave that epinucleus. I don't want to take a chance. So I go ahead and take the chopper out, push BSS in, take the phaco tip out, and go in with the INA handpiece. The INA handpiece obviously is rather safe because you have the polymer tip. And so there's no reason to be a hero when you don't have to be. Just go ahead and take the epinucleus out with the INA handpiece. And then I go ahead and switch to polish mode, polishing under the rexus edge, going around circumferentially, polishing the lens epithelial cells. Again, I want to be rather expeditious in this case. I'm not going to perseverate too much. And because this patient can suddenly jerk anytime, I'm not going to really do the pulsing of the BSS into the subincisional capsule fornix too much because it's just too risky. So I go straight to the cohesive viscoelastic to fill the bag. And then I'm going to go ahead and bypass the sweep as well. There's no reason to sweep, especially if the patient suddenly moves. I only have one hand in the eye. So I go straight to the lens. I put the lens into the capsular bag. Go in with the INA. Disengage the haptics off the optic, getting underneath the lens, tilting it, rotating it 90 degrees, removing all the viscoelastic from within the bag. Repositing the lens back down, just skipping polish mode, go straight to visco mode, remove all the viscoelastic from the anterior chamber, and then I say, okay, I'm going to just polish a little bit. So I go ahead and switch back to polish mode, polishing under the rexus edge a little bit more. I'm noticing the patient's not as jerking as he was in the beginning of the case, and so I just said, okay, let's go ahead and do some polish. Switch back to visco mode, remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, from good to great, number 6 tip is really making sure you're not floating with your hands when you're doing cataract surgery. Imagine if your hands are floating and the patient suddenly moves his head towards you. Your instruments don't have time to react, and you can literally impale the patient's vitreous space and potentially the retina if you're not very careful. So it's always important to have a fixation point, a resting point for your hands. And so I always rest my hands, both my hands on the patient's face. Whenever you're doing any maneuver, always rest your hands, even from the very beginning when I'm hydrating the incisions and I use my cotton tip and I make my incisions and all of those types of things. All of those maneuvers, my hands are resting on the patient's face. And by resting on the patient's face, if they suddenly move, your hands will also move with the patient, just like a rodeo rider riding that bronco. If the bronco moves and you're sitting on the bronco, the rodeo rider will also bump around and move with the bronco. And so it's the same concept. If the patient moves all over the place, if your hands are on the patient, your hands will also move with the patient for the chances, therefore, of a catastrophic complication where you impale the posterior capsule with an INA handpiece or the hydrodissection cannula or whatever that may be. It's going to be much reduced because your hands are resting on the patient. And you saw how awful this patient's head movements were, the extreme head jerking. This was probably one of the worst cases I've ever seen of a head jerking. I think the only way to alleviate this would have been to do a general anesthesia. I really don't think retrobulbar block would have helped because the patient wasn't moving his eye, he was moving his entire head. And you saw I had to readjust the scope in the middle of the case because I was so off the focus of the microscope. And so, again, resting your hands on the patient, it steadies your hands, number one, but it also allows you a protective mechanism in case the patient has an extreme head jerking movement. So I hope this was helpful to you, and I thank you for your attention.